but I don't want to record. A 50-year-old gentleman presents with a history of focal epilepsy with seizure onset in his 20s, has been on phenytoin monotherapy for over 2 decades, and has been seizure-free for the past 12 years. His recent bone density testing shows him to be more than 2 standard deviations below the age and gender-adjusted normative results. His most recent MRI and EEG from within the last year are normal. Assume for purposes of answering this question that you have counseled him on the risks and benefits of all approaches and he wishes to follow your recommendation. Given the scenario above, would you 1. Continue the patient on phenytoin, 2. Transition to an alternative medication, or 3. Discontinue medication? You can also say, I would likely to do 1, but it would depend. So what is your response?
So I know what I would not do, and that is number 1. I would do either 2 or 3 with explanations to the patients and taking, of course, his input and the input of the family. But in fact, I was even surprised that 1 was an option, and I was really looking forward to the arguments of whoever would like to do 1, because that's the one thing I don't think I would do. I don't think any of those 3 responses, of course, is wrong, but I have a strong preference for 2 and 3. I will try for 3 first, which is if he's been seizure-free for 12 years and if he is interested in getting off medications, I would offer a slow weaning, explaining, of course, that there is a risk of recurrence, and it depends if he's eager to get off medication. If he wants to be more cautious and he is really, really apprehensive about having another seizure, then I would transition to a more modern AED, so tapering the phenytoin and increasing one of the modern AEDs, which has less interaction and is not an inducer, to replace the phenytoin.
So obviously, we're not going to be that far apart because I believe we both have the best interests of the patient at heart. But I do have some circumstances under which I would indeed continue the person on phenytoin. So we're never talking in this circumstance about I would always do A or I would always do B or C, because it's really going to depend on that particular patient and that particular patient's circumstances. But I do have a few reasons why I would leave the person on phenytoin. And by the way, in the recent Q-Pulse survey, that was by far the least popular answer. So let's talk a little bit. Let's talk a little bit about what the risks and benefits are of leaving them on phenytoin versus doing one of the 2 other things. So first of all, let's talk about completely discontinuing medication. Certainly the history of that person and what had happened to them in the past would color what you would do under this circumstance. So for example, I'm sure you would agree that if the individual had been tried to be weaned in the past and had had a seizure under those circumstances, you would be far more circumspect about trying to wean them again.
Absolutely. I assume, since it wasn't specified, that he has never had a trial of getting off the phenytoin. But very good.
And the second thing is if in the past, before he got on phenytoin, for example, he had been difficult to control in the past, or if he had had seizures where he injured himself, these are also reasons why you'd be a little more concerned about stopping his medication.
Sure, or an episode of status epilepticus, yes, things of that nature. Absolutely.
Exactly. And then we go to the second choice, which is switching him to a different medication. And, no matter what medication you start him on, he is going to be subject to the possibility of having side effects on that medication, where we presume that he has had no side effects on phenytoin. So, that has to be taken into consideration as well. And maybe it would be a mild side effect that could be dealt with, or maybe it would be something more severe like a rash with lamotrigine. But you are subjecting him to a new chemical that he has not yet been exposed to. And then,
but some would argue he is having side effects with his bone density, although this is asymptomatic, of course. But
And so let's get to that, which is the risk of continuing him on phenytoin, which we know at least is an effective therapy for his epilepsy. And in circumstances such as this, I have sent people to bone specialists to get their opinion. This has been in some circumstances where, the patient perhaps has been tried on other medications and has failed already. So maybe even more reason to leave them on phenytoin. And I have gotten a response that kind of surprised me, which was that in men, even with 2 standard deviations below the mean, there is actually very minimal risk to no risk of fracture. And certainly they have to be have even more significant bone loss in order to put them at risk. And obviously, under those circumstances, if you did decide that you were going to leave somebody on phenytoin, you would want to scrupulously pay attention to, putting them on vitamin D and calcium and doing frequent DEXA scans, bone density studies. But under those circumstances, I think that these bone density experts would say that you do have room to continue them and see how they do if you are weighing off the potential of a risk of the phenytoin versus the risk of a recurrent seizure. And I just wanted to also add that in the Q-Pulse survey that we did, it was interesting that, I have the results here, that we asked the people the 99 people responded to the Q-Pulse survey who were all the heads or assistant heads of epilepsy centers. And we asked them if they had ever seen any kind of catastrophic result as a consequence of changing or switching people on their medication. And 20% of them said they had seen an injury or an accident. And a little less than 5% said that they had seen a SUDEP in that circumstance. Some said that they had seen status epilepticus. Some said that they had seen seizure recurrence that then could not get under control. And, since I've been doing this for a long time, even under very, very careful circumstances, I have seen people have these consequences. And in a few circumstances, I've seen them have it as a consequence of switching from carbamazepine or phenytoin to one of the newer anti-epileptic drugs, because although we presume that they're just as strong, it's not always the key that fits that particular person's lock. So you always are taking a small amount of risk, and you would want to know whether that person is risk averse, and you would at least have to tell them, if you were switching them to a different medication, that there is some risk that they would indeed have a breakthrough seizure under those circumstances.
Interesting. What about other downsides of an enzyme-inducing AED? It didn't say about comorbidities and so forth, but it has a lot of other impacts on other medications and so forth. Now, we don't know if he has any or not. But what if he was a woman? Would that change your approach then?
I think I would be more concerned about the bone density in a woman than in a man. And I absolutely agree with you that doctors probably don't take the consequences of enzyme induction seriously enough. So in this particular case, or in any case, you would certainly have to really evaluate not only the bone density, but as you said, other hidden consequences of being on an enzyme inducer. There's this study by Scott Mincer that says that things like homocysteine can go up into abnormal ranges, and serum cholesterol as a result of being on phenytoin or carbamazepine. And if you actually get people off of those drugs, they often have a reduction in their cholesterol. And I have many, many examples of people who are on enzyme-inducing anti-epileptic drugs who suffer consequences that most people have ignored, such as being put on drugs that don't work for them because nobody bothered to adjust the dosages of those drugs in response to them being on an enzyme inducer. I had a woman who had a terrible fungal infection because the ketoconazole that she was put on was insufficient to suppress it. So, you hear stories like that all the time.
Yeah, no, in this case, to defend your position a little bit, it doesn't say that he has comorbidities, HIV or what have you, that he's taking another medication whose effect will be decreased by the inducer. But let me ask you another question. If you are hesitant to switch him to something else, I assume you're even more hesitant to wean him off meds. So if we don't offer somebody who is seizure-free for 12 years to get off seizure medications, to whom do you offer that?
Well, that is a very good question. There now are studies like the study of Kwan and Brody recently in neurology saying that epilepsy is not quite as simple as we have always made it out to be, that once people are seizure-free for 2 years, you can predict that they're going to be seizure-free long-term, and that really people with epilepsy are on a roller coaster ride, where sometimes their epilepsy will sort of go underground for long periods of time, and then it will rear its ugly head again. And that, a lot of people, if you follow them long enough, will actually have waxing and waning episodes of seizures. That there are some people who, have seizures, get on medication, stay on medication for 2 or 3 years, come off, and never have another problem with epilepsy. Certainly they do exist. But I think that really we haven't done enough long-term study of people to know what percentage of the population that actually comprises. And, we keep people on, for example, statins and antihypertensives, even though the number needed to treat is something like 22 or 23. So that means that for every 23 people who are on statins, only one of them actually needed it, and the other 22 never would have had an adverse event if they had not been on a statin. And yet they take those statins every day of their life. Are you on a statin? So, so we as a society, we've made these decisions that there are some consequences that are bad enough that we will treat a lot of people who don't need to be treated to prevent one person from getting into trouble. And the question is, what is that balance? And I don't think as a community we've talked about that balance in epilepsy enough and really discussed it.
But I am sure you have weaned people off their seizure medication after being seizure-free for, let's say, 5, 10, or 15 years. And then you're right, it's a difficult, and it's so individual, per physician, per patient, and per circumstances, and per patient preference, the type of epilepsy, etc. So Interesting discussion. At least I came in here thinking there is no way somebody could argue for number one, but you did a good job.
Thank you. This debate will definitely continue.
Yes, I'm sure.